So it is my pleasure to introduce Dr. Shruti Shankar today to speak with us about progressive pulmonary fibrosis. And on a personal note, I think this is an incredibly important topic. My colleagues and I have really struggled over the years to try to figure out how to best to treat these patients. We immunosuppress people and see people progressing. And really, this has been a group of underserved patients where the trials were designed towards IPF. The treatments, therefore, were approved for IPF. And so it's really lovely to be able to see this expanded group of patients that has research and therapies directed toward them. So I'm really looking forward to this presentation. On that note, I will introduce Dr. Shankar. So Dr. Shankar is a second-year fellow in our pulmonary critical care and sleep medicine program. She graduated from the University of Virginia and then completed residency at the University of South Florida, where she was recognized as an exemplary resident. Since medical school, she's amassed a good number of presentations and publications, even at this early stage in her career. And she's already engaged in a number of clinical research projects focusing on a variety of things, including ECMO, lung transplantation, and idiopathic pulmonary fibrosis. And she's been able to present her findings at ISHLT, at Society for Critical Care Medicine, at CHEST, and has a number of publications. We are very happy to have her involved in clinical research with the ILD program, and I'm looking forward to her presentation on progressive pulmonary fibrosis and the potential role of biomarkers. So thank you.
Thank you, Dr. Antonizirkis. Thank you, everyone, for being here, and welcome applicants. I'm really happy that the ILD community is here because obviously this is just the beginning of my research career into progressive pulmonary fibrosis. But I wanted to give the fellows also an insight into what's going on at Yale and how we've contributed to this field. All right, so this is the CME disclosure, if anyone wants to write that down. Okay, so objectives for this talk, we're going to talk about why this quote unquote novel clinical phenotype has emerged. It's actually been here for a while, but now it's actually defined as a term called progressive pulmonary fibrosis, what the prevalence of this is within fibrotic ILD, and what the definition of it actually is, the limitations of this proposed definition, and then we're going to talk a little bit about biomarkers and what insight we can get from those. So very basic to start off with, what is fibrosis? It's thought to be multiple healing responses that have gone wrong. The local environment basically becomes overwhelmed. There's a lot of chemokines, pro-inflammatory changes, angiogenic changes, fibrogenic changes happen. There's growth factors involved. And that basically results in an accumulation of more extracellular matrix components and some fibrotic changes. So it's basically becoming a perfect storm of damage and reconstruction, not fully understood, but that's what we know so far. So that's what we see in the pathology part. In the clinical side, on the CT, I'm sure you all are familiar with the honeycombing, traction bronchiectasis that we can see. There's distortion of the lung architecture as we would expect with a fibrotic lung reticulation. Some cases you can see interlobular septal thickening, but this is not specific to fibrosis. So historically, there was always a focus on IPF. That was the hot topic. There's a lot of research on it. And then there's now this new character, quote unquote new. This has been here all along, but now he has some more recognition. And so now we're starting to see some more data on other ILDs and are noticing some similarities, some differences, and we need to explore this a little bit more. So beyond IPF, we'll look at the biologic perspective. We've noticed that there's a lot of common biologic mechanisms. There's shared genetic predisposition between rheumatoid lungs and IPF that have been proven, similarity between short telomeres, telomere mutations between different ILDs. Systemic sclerotic ILD in particular has been actually studied quite a bit and made quite a few links between that and IPF. And that's more in the pathogenesis sort of field. So there's a lot of talk about alveolar epithelial cell dysfunction that's pretty similar in between the two. Clinically, as physicians in the clinic will see these patients kind of progress similar to our IPF patients. So RA, HP, systemic sclerosis, these are all examples of fibrotic diseases that actually we see progress pretty similarly, even if they're not a UIP pattern. And we see this happen despite putting them on immunosuppressive, immunomodulatory therapy. And then finally, we're going to talk about treatment. There's multiple trials that have been done now this far. They show similar efficacy of anti-fibrotic drugs in non-IPF diagnoses now. And then we'll also talk about practical limitations of designing these studies. So first, biologic mechanisms. We'll talk about genetic predisposition. The most common thing that people talk about is telomere length. This is a study that looked at familial interstitial pneumonia and compared telomeres to that from other ILDs. And so, as expected, the one with TERT mutations is lower on the telomere to single copy gene ratio. And you see that these other ILDs are actually also low compared to the control, which is up here. This is sarcoid up here, which is the least variant compared to the other ILDs. There's also telomere mutations in rheumatoid ILD. So this is a study that looked at controls, normal French Caucasian population, and rheumatoid ILD, and they saw that there was a lot more incidence of telomere mutation in rheumatoid ILD. So we can talk about fibrosis itself now. There's the UIP pattern that we see typically with IPF. This is also in different progressive fibrotic ILDs, like you'll see with rheumatoid, fibrotic HP, for example. Here we see the honeycombing, traction bronchiectasis, reticulations, like we talked about before, and there's collagen deposition similar to what we saw for UIP. And then outside of UIP, there's other patterns that we'll see on CT imaging. So this fibrotic HP lung kind of looks similar to the UIP with the honeycombing here, but here you'll see different reticulations here, mosaic attenuation, some distortion of the lung architecture. And then there's fibrotic NSIP, which is the classic subpleural sparing that we know. So not all ILD is fibrotic, and not all fibrotic ILD becomes progressive. This is a nice table that just kind of outlined which fibrotic ILDs could become progressive. The most common that we were thinking about, idiopathic, NSIP, connective tissue related, HP related, sarcoid. So we can talk a little bit more about prevalence and how they act. So this is a study done in mixed connective tissue ILD, and it looked it divided basically patients into 3 groups. So they looked at high-res CTs in a certain period of time. One group had no ILD progression based on high-res CT. Another group had stable ILD, and one had ILD progression. And they kind of looked at the pulmonary function tests as expected without ILD, FVC from initial high-res CT, and to follow up kind of remain the same in both in no ILD and stable ILD. And then with progression, you've noticed a decline in both. The mean follow-up time for this study was 6 years between CT scans and pulmonary function tests. This is the same study, and it was looking again at high-res CT, and it kind of quantified the amount of ILD per total lung volume seen on CT scan. They used a cutoff of 5%, and those patients with greater than 5% of ILD on their CT scans had a significantly lower survival rate. So they're saying that the amount of ILD on imaging is correlated with mortality. This Canadian registry, this is a prospective cohort study over 5 years. They basically defined progressive fibrosing ILD in their own sense, in that they, this was the definition. They used relative forced vital capacity decline of 10% or greater, death, lung transplantation, or any two of these three, which are FVC decline between 5 and 10%, worsening respiratory symptoms, and worsening fibrosis on CT within 24 months of diagnosis. And you can see IPF is up here. This is they had the most amount of patients in the IPF group, but the patients that meet this progressive criteria, it's about 50% in IPF, 50%, 60% in HP, 50% in connective tissue. So this pattern is pretty similar in multiple different ILDs, which is what they were trying to show. This is that same study using the Canadian registry. It actually shows a pretty similar progression with IPF and HP, which we'll talk about in a second why that's interesting. But connective tissue and unclassifiable ILD, all of these had kind of varying progression rates over time. So the authors make a note that when they were doing this study, this OFEV or nintedanib had not been improved in anything other than IPF. So all these patients, or 68% of these patients with IPF, were on antifibrotics, while all the others were not. So you can't really make that rate or the conclusion of similar progression rate because of the treatment differences exactly. And then 60% of the patients in the other groups were actually receiving immunomodulatory therapy too. So. This is a study looking at risk factors for PPF phenotype. They actually looked across all the data in thus far in 2021. And they identified different studies that kind of looked through different risk factors. UIP pattern had a higher hazard ratio for predisposing to progressive phenotype. Oxygen desaturation during a 6-minute walk test also did the same. There's a lot of similarities between different studies and within or across different ILDs. For example, a decline in FVC 10% or greater is been shown in multiple studies and in different ILDs as being a significant associator with progression. Mutations like MUC5B, and then decline in DLCO of greater than equal to 15%. The other thing they note is the extent of fibrosis on high-res CT, like compared to another study we'd already talked about. This is part of the new ATS guidelines. It's developed using consensus by discussion, but these are thought to be the ILDs that are other than IPF, and they're highlighting what proportion of these, which are more likely to have progressive fibrosis. So HP, they're saying about 50%, kind of similar from what we saw in the Canadian cohort study, that can be progressive. Other ones they highlight are occupational, systemic sclerosis, RA, unclassifiable. So now we can talk about treatment options. The first study done outside of IPF was the census trial nintedanib for systemic sclerosis related ILD. Now note, this is not for a progressive fibrotic phenotype group, but this is the first study that was done outside of IPF. And it was done because there was those similarities that were observed in pathogenesis between systemic sclerosis and IPF. And even though at that time nintedanib was used for UIP/IPF, and SSC has more of an NSIP pattern, they went ahead and used this, and they actually saw that the nintedanib plus an immunomodulatory agent had the best outcomes for people with systemic sclerosis. So this was done in 2019. Just before that, there was a commentary paper that basically said, it's not feasible to do this kind of study for every little ILD, because a lot of these are rare. It's hard to get recruitment, and it's just unrealistic. So I like this quote: after 20 years of experience with large multicentral IPF trials, we were that a rigid approach requiring that the efficacy of newly identified disease-modifying therapies must be demonstrated by controlled data in each individual ILD is unrealistic, inefficient, and may disenfranchise non-IPF patients with a similar clinical course to IPF. So actually, just after that paper, the INBUILD trial came out. And this actually did the same thing that they had asked for. So they lumped all these people into one big category so they could have more power, and actually used nintedanib in a progressive fibrosing group. The criteria for this group, they used a relative decline of FVC 10% or greater if predicted, relative decline of FVC 5 to 10% plus symptoms or plus worsening on high-res CT. And then, or there's worsening symptoms and worsening fibrosis on high-res CT. And this was a double-blind placebo-controlled phase 3 trial. It was conducted across 15 countries. Prior to this, like we saw, nintedanib was only approved for IPF and systemic sclerosis. So this was definitely an advancement in the field. This is from a different paper, but they looked at all the patients that were used in the INBUILD trial. So we can see that there's UIP-like and non-UIP-like, and there's a lot of different ILDs that have been used. Hypersensitivity pneumonitis, in particular, is one that we've seen kind of commonalities throughout. And here is the efficacy chart on there. So the change from baseline is kind of the primary endpoint for annual rate of decline of FVC. And this graph shows that the mean change in baseline of FVC over 52 weeks was slowed with nintedanib in the overall population and the UIP like fibrotic population. Another trial done shortly thereafter was Pirfenidone, an unclassifiable progressive fibrosing ILD. So they chose progressive disease as in the prior 6 months, if this patient has had more than 5% absolute decline in predicted FVC and a significant symptomatic worsening. The primary outcome was actually done with home spirometry. So as you can imagine, it wasn't totally reliable. And so there was no significant change in that primary outcome, but they did have some changes in the secondary outcomes that they outlined. So one would be site spirometry, FVC change from baseline. And that one's statistically significant when you compare Pirfenidone to placebo. Greater than 15% decline in DLCO happened less frequently with Pirfenidone than placebo, though granted these are very small numbers. Pirfenidone again looked at progressive fibrotic ILD other than IPF. This is the RELIEF trial. So this one again, a different classification of what progressive fibrosis actually means. So this is an annual decline of FVC greater than or equal to 5% predicted in the last 24 months. This one had insufficient recruitment and was terminated early. But again, they also published some secondary endpoints that they thought were interesting in it. They showed that patients in the Pirfenidone group, which is in blue here, were less likely to have more of a significant decline in percent predictive FVC. So this group is a decline in less than 5% or no decline. And here's 5 to 10, and here's greater than 10. So there's some ongoing trials at Yale right now, Fibroneer and Aloft. They're both kind of attacking different pathways in the inflammatory cascade, and patients can be signed up for that too, even if they're on OFAB. So what's in a name? That's a Wells that Al had kind of brought up before. Why are we doing different trials on these small rare diseases when we should be seeing them as a whole? So kind of distinguishing first fibrotic ILD in general from progressive pulmonary fibrosis. PPF is despite immunosuppressive treatment, and it's worsening fibrosis and symptomatic or physiological evidence over time. One paper estimated 13 to 40% of non-IPF fibrotic ILDs will progress over 2 years after diagnosis. And as we saw before, some are more likely than others. So finally, this is the ATS statement from 2022. After all these trials have been done, it's kind of a combination that they use from all these trials, and then also things that they've seen in the literature, including from IPF. So they say that to have progressive pulmonary fibrosis, which is a phenotype, you need at least 2 of the following. So either worsening respiratory symptoms and physiological progression, or radiologic progression, 2 of 3. So physiologic progression, as you saw before, some use absolute, some use relative. This one uses absolute decline in FVC greater than or equal to 5%, and absolute decline in DLCO greater than or equal to 10% within 1 year of follow-up. So it's either or of those. Or there's radiological progression on high-risk CT. They did want to make clear that it's defined separately from IPF and it's not a diagnosis. So this is a phenotype, and it's more to understand kind of the possible prognosis. It's unclear if this has implications for antifibrotic therapy. So we'll talk about this criteria and validation and limitations of it. So this is a study that was done to correlate certain criteria that were done in both the ATS 2022 guidelines, but then also in prior studies. So they actually had looked at the end outcome of death or lung transplantation rather than FVC decline. So here they use 10% or greater FVC decline. They saw was significant risk for death or lung transplantation. And these below are all if they did not have the greater than 10% FVC decline, so kind of on its own separately. It's the 15% or greater DLCO like we saw before, CT progression of fibrosis on its own. And then there's some with symptoms like 5 to 9% FVC decline with worsening symptoms, progression of fibrosis and worsening symptoms. So using this criteria, they actually said that meeting 2 of 3 of the criteria from the ATS guidelines is specific, but it might be at the cost of sensitivity. And here they were actually trying to say that maybe FVC decline greater than 10% on its own should be a criteria, irrespective of symptomatic or radiological worsening. This is debatable, but here they show increased mortality for those patients with FVC decline greater than 10%. There was one paper that did look at validation of FVC because there's so much variability, and there's a lot of papers with that say that it shouldn't be used as a marker or isn't applicable for mortality. But this actually says that maybe we can look at rate of change within patients as a marker rather than like an absolute or relative change. And this used all the Nintendo trials data, so like IPF, SSC-ILD, PPF. And so they had a pretty large N number. And they saw that there was an increased risk of death that was associated with a greater rate of FVC decline in percent predicted, and also increased risk of death with the lower current value of FVC percent predicted. They saw that these results were consistent between IPF and other ILDs. So now we can talk about limitations. So like we said before, the criteria were primarily based on IPF. There still needs to be a lot more research within this kind of specific group in general. The criteria have also not been used consistently across these studies that brought up progressive fibrosis as a phenotype. The ATS guidelines came out in 2022, and a lot of the studies that we saw in INBUILD Relief were 2019, 2020. FVC decline, we kind of talked about already. A lot of papers use absolute versus relative, varies. There's variability in the measurement as well. There's inter and intrapatient variability. The centers do it differently. So it's kind of been argued that it might not be the best marker. It's also might be less sensitive, like the other paper had suggested. You have to meet 2 out of 3 criteria. And then some of the other trials only used one variable to quantify progression. And then also there might be a dissociation between all of these criteria. There might be, radiographic worsening, but not symptomatic worsening, for example. And the role of the UIP pattern, a little unclear if it makes it a worse prognosis, because those also vary between the papers that we have. And then finally, these guidelines were proposed without a full understanding of the disease process. It's based solely on phenotype. And so we don't really know what the genetics, the response to therapy mean in this with these guidelines. So for the future, rather than having these criteria, could biomarkers be a better predictor or a more reliable predictor for disease progression? For biomarkers, there's a lot of different sources: peripheral blood, parenchymal, radiologic recently, and they might help to inform diagnosis like they do in a lot of other organ systems diagnosis, outcomes, guide treatment processes, and we're hoping to find the same in IPF and PPF. So a common peripheral biomarker in the literature is higher monocyte counts. The classically reviewed monocytes are CD14 and CD16. Here they showed that patients with a lower monocyte count, which is in the green, had a higher transplant-free survival. And then here is actually a trial done using our Yale cohort as well they're showing that there's the higher monocyte count has a higher risk of progression. This is done specifically in IPF. Other monocyte counts, this is using Stanford Northwestern data as well. These are hazard ratios for monocyte counts and outcomes in systemic sclerosis, ILD cohorts. And they have been adjusted for either FVC or GAP, which is Gender Age Physiology Index. So they show that that the higher the monocyte count, the worse the outcome, essentially. These are the combined hazard ratios for all three. One done in our very own lab, mitochondrial DNA by Dr. Ryu. He's actually been researching a lot about mitochondrial DNA and UIP, sarcoid, scleroderma. This particular one is looking at scleroderma ILD. Their cohorts from Boston and Yale. And compared to control groups, the Boston and Yale cohorts did show increased concentrations of mitochondrial DNA in the blood. And then they also found, use this receiver operator curve to find like high risk and low risk cohorts, which they then applied to look at probability of preserved FVC. And you see the probability of preserving once FVC goes down, the higher the risk with higher mitochondrial DNA in the plasma. This is something that we've actually been using at our ILD center, which is INBUILD. It's a pathologic biomarker, which is a genomic classifier. It's basically a high rule-in, as in not diagnostic, but rules in UIP diagnosis, and it's been trained by machine learning. So it basically uses a gene expression signature on transbronchial biopsies. And it has a pretty high sensitivity for UIP. So for one single transbronchial sample, the specificity is 86%, sensitivity 63%. The performance improves to specificity of 92% with 3 to 5 transbronchial samples. And this can help to differentiate between UIP and non-UIP ILD. But there is growing research on how can this be applied to potential non-IPF diagnoses. So as you can see here, sometimes they do end up positive for non-IPF, but most of the IPF are positive, so these are statistically significant. So here, this is basically showing that the UIP or GUIP classification strongly associated with in IPF diagnosis, especially those with probable UIP or indeterminate pattern on high-res CT. So, and that actually increased the odds of an IPF diagnosis by more than 60-fold in each group. But for these non-IPF ILDs that were GUIP positive, it's actually been shown to have increased progression of disease. Not the same for those that are GUIP positive in the IPF group, but in the non-IPF ILD, those patients that end up being positive have been shown to have increased progression. So could be helpful to identify PPF patients early on and start antifibrotics. And we can talk about radiology too as a biomarker. There's quantitative CT and machine learning that's been used to develop specific digital biomarkers. One quantitative CT is Caliper, stands for computer-aided lung informatics for pathology evaluation and rating. So this one, the computer is actually trained by a human operator to identify certain patterns and to quantify it. actually part of Caliper was to extract pulmonary vessels so we could look at the parenchyma a little bit better. But this actually inadvertently ended up becoming a biomarker for progression. So it's called like vascular related structures, pulmonary vessel volume. We'll talk about that on the next slide. But Caliper in general is used to look at like ground glass, reticular pattern honeycombing, and it basically creates this volumetric like signature mapping on the CT. So pulmonary vessel volume, they've actually shown can be a predictor of mortality. They used a higher threshold for pulmonary vessel volume just so they would kind of remove the misclassified reticular pattern that can sometimes look like vessels. But there's they've been shown that it's higher risk of mortality with pulmonary vessel volume and with what we'd expect with worse honeycombing, ground glass opacities, reticular patterns. Another type of computer-related learning, SOPHIA, systematic objective fibrotic imaging analysis algorithm. So this is deep learning. You don't need a human operator. It autonomously identifies patterns on high-res CT. So it basically takes little cuts like this throughout the entire CT and makes it, highlights the pixels that it thinks are significant for fibrosis, like the peripheral honeycombing over here, that would be looked at like hotspots. And that contributes most to the analysis. And they've shown that those scores actually do correlate with mortality. So the way that they've been using this is that they basically quantify the SOPHIA score between low, intermediate, high probability pathognomonic for UIP. And that's what they had charted against. So this, which would be pathognomonic for UIP, has the lowest survival. Not used in clinical practice yet, but kind of a way that we can start to think about how these biomarkers could be used is this scoring system that uses honeycombing, traction bronchiectasis, and the monocyte scores like we had talked about. And they looked at risk of progression, the higher the score. So basically the higher the score, the higher the risk of progression. So potential future directions. We have an IPF cell atlas with our very own Kaminsky lab. So this is a multi-institutional collaboration. They use single cell RNA sequencing data sets, and that can help analyze the cell type, the functions, molecular signatures, interactions, and users can actually input this into it for novel disease and cell-specific expression patterns. So question is, maybe, is there a role for a future PPF cell atlas? So looking forward, how can we use this data in clinical practice? So this paper kind of looked at all the combination of all the available information that we have, and we haven't quite put it together yet on how to use it, but the possibility of kind of incorporating everything and at the same time having home information like home spirometry, SpO2, cough monitoring, making an early diagnosis of progressive fibrotic ILD, and starting antifibrotics early and considering them for lung transplant early. So in the future, there possibly could be a scoring system that could help us for this. So key points, there's growing data on this shared pathologic, genetic, prognostic markers between IPF and other ILDs. PPF is a clinical phenotype, and it's more meant to kind of suggest an increased mortality, potential treatment implications, but more of a prognostic indicator at this time. There's limitations, as we don't have enough data, enough research on the background of this, and we don't totally understand the disease processes. Biomarkers might help us identify these patients sooner. And this combination of pathologic, genetic, radiologic evidence, it could allow us to identify patients sooner who need treatment with antifibrotics or lung transplantation. So these are my references. It's PDF if anyone wants to look at it. I want to say thank you to the entire ILD group. They've helped me a lot, especially with this presentation and future goals for research. I do want to make special mention to Dr. Galati and Dr. Antonis for helping me with this presentation today. And Dr. Galati is my mentor for future research projects. Dr. Mathe and Dr. Kaminsky for giving me the opportunity to speak today. Dr. D'Ambrosio and Dr. Clark for their continued encouragement and forever support, and my co-fellows, without whom I would not have been able to get through all of this. Thank you.
Thank you. Thank you very much for that comprehensive talk. It is now open for questions. Oh, we have a lot. Let me start heading to the audience. Dr. Homer.
Thanks for the great talk. So a lot of the biomarkers you mentioned, especially the radiology ones, like the HTM, they seem to be a marker of progressed disease rather than progressive disease. So I was wondering if you could comment. I mean, seems like one of the things that we're really keen on is really understanding the people with ILAs and the people who have not yet really don't have very much disease, because that seems like the area that we would really want to sort of strike on the hardest, because those are the people we probably can attempt to do something for right now. I was wondering if you could sort of comment on that concept.
Yeah, sure. I agree. It's more progressed, but I actually think that computers have better eyes than we do, and a lot of the progression that we see from high-res CT and these other studies are more based on the human eye, which can also be a little bit variable on who reads it. So that's what I interpreted as the use of the kind of AI version of this.
All right, we have another question.
Yeah, I'm sorry if you mentioned and I missed it, but when you mentioned about monocytes as a biomarker, right? Is there a difference in how much you see like classical monocytes or non-classical, or is it like both increase in the?
I believe they're both increased, but the ones that are more in literature are the CD14 and CD16 that have been looked at, most specifically with IPF.
Okay, thank you.
Thanks so much. That was really awesome. In the INBUILD trial, I actually don't know this. Did they differentiate the response to the OFEV based on the type of like pulmonary fibrosis, like IPF versus connective tissue, or different connective tissues?
Yeah, they did based in the other data that they had is mainly in like a supplementary data, and so they published a different paper with all of that. I'd have to look through that for the chart for you. Yeah.
So I found the data regarding the vessels being a predictor of progression being quite interesting. So I had two questions. First of all, was it more vessels or less vessels that were predictive?
More vessels predictive of increased mortality.
Okay. So then when you think about the data from nintedanib versus Pirfenidone in progressive fibrotic disease. If you think about the mechanisms, at least the proposed mechanisms of nintedanib having potential an angiogenic effect given the VEGF connection versus Pirfenidone, could you think of a synthesis of the radiographic progression data and the results in the PF-ILD studies where nintedanib showed some efficacy and Pirfenidone did not?
From what I gathered, Pirfenidone, the studies were just not done quite as smoothly and had a little bit less recruitment. So I think it's hard to say because some of the secondary outcomes did show some kind of benefit, but that might be why nintedanib is consistently kind of shown.
Yeah, I mean, I think when a study's negative, there's a lot of reasons why a study could be negative, but we also have to be able to reject or accept the null hypothesis, which is maybe there just wasn't a difference. But you're pointing out why it's so important to plan your study well and maybe use the gold standard approach when it's something as high impact as a randomized controlled trial than going with the latest greatest like home FVC.
That makes sense.
I don't know if we'll ever know about Pirfenidone and PF-ILD if that's ever going to pan out or not. But good job with this presentation.
Oh, thank you.
Dr. Malveich?
Could you explain why it's thought that monocytes are important in this disease? What do we know about it specifically? What research? I'm sure Dr. Kaminsky would probably have some thoughts on that too, but it's interesting. And then the other one was the mitochondrial DNA, why this might be of an issue, either one or both of those.
Yeah, I think both are actually linked to this inflammatory cascade that we think is the reason for all of this fibrotic development. So the monocytes would be the inflammatory cells, and then the mitochondrial DNA actually released after inflammation occurs or injury occurs. But I know that's Wani's area of expertise, so correct me if I'm wrong, Wani.
Wani, feel free to.
Yeah, sorry. Yeah, so at least in scleroderma, probably, there's both inflammatory and fibrotic elements. And so we think that there is chronic innate immune activation that mitochondrial DNA mediates. So that mtDNA works as a ligand that acts on different innate immune receptors. And so that's the angle that we've been looking at in scleroderma. And we see that in IPF as well. I think the IPF community has adopted more of a inflammatory myofibroblast approach so that there is elements of inflammation present too.
So I think you highlighted very well the point of view that actually progressive pulmonary fibrosis is not a disease. So how do we deal with the thing that our clinical practices are determined basically by an enrichment strategy for a clinical trial? Right, because I find it a little bit confusing because one is you need to wait for your patients to have progressed to know that they have progressed. And second, it's a huge lump of diseases that actually do behave differently. So do you think that this is just a temporary state and will probably go to better classifications of disease in the next few years, or? You can say yes, because that's what I think.
No, I think, like we saw, there was other, I guess, other outcomes or other markers that actually also showed increased risk of mortality. So that's what one of the papers are saying, like for ATS to say you need these 2 out of 3 to qualify, that is definitely going to leave out some people. So I think there just needs to be a little bit more research, and once these people are actually identified on how to hone down this classification or kind of broaden it to include the people that we're missing.
I'll make one comment about the monocytes and just to, one is there's a problem with the monocytes, and the problem is that
the idea that monocytes increase in progressive disease came actually as an extrapolation from a study of gene expression done by Jose. And here's the thing. That study was done on PBMCs and peripheral blood mononuclear cells. So actually, there were no neutrophils in this study, for instance. So maybe neutrophils are predictive of outcomes. That's one thing. But the cool thing, it has been validated that actually if somebody has over 900 monocytes in a count, it is almost in every study, it's a marker of disease progression. What we think based on the IPF cell atlas and other work is that, and some of the work of Emi Zhao in my lab, is that monocyte, the sort of the recruitment of monocytes from the blood, and the sort of the fibrotic monocyte-derived macrophages in the IPF lung is actually universal to almost all fibrotic lung diseases. So Amy has shown now, and others, that basically, if you want to, in a very simplistic approach, what's universal, when you have fibrosis in the lung, you're going to have these profibrotic macrophages that are monocyte derived, and they usually go with the CD14 monocytes in the blood. The differences between the different diseases are actually in the other cells. So when you want to know if it's an autoimmune or another, is it the lymphocytes going down, CD8s, others? So I think the more interesting future biomarkers are going to be actually in the other immune populations. I have to say something about that.
Well, I think another interesting way to look at it is that the cells in the blood, the monocytes, have a fibrosis promoting phenotype before they're in the lung or when they're not in the lung, which could mean any number of things, but it's intriguing to consider that perhaps there's a bone marrow defect, which then could get back to the whole telomere in the circulating white blood cells, which hasn't really been studied yet, but potentially could be by anybody in this room who's interested.
I think we have a couple from Zoom. Where so Kai Ying asks, are pulmonary vascular volumes, is the pulmonary vascular volume decrease associated with progression?
No, it was the increase on Caliper.
It was increase. Okay. And then let me just see what else. Just people telling you that you did a great job.
Oh, thank you.
And so I think with that, unless there are other questions, we will conclude, but I think thank everybody for their attention and terrific talk. Thank you.